late pregnancy bleeding. So this is a new topic for us and very, very important one. So let's talk about it. Now, all of you, please have a look at this slide. Okay. In this slide, you can see two very important causes of late pregnancy bleeding. Can you identify what are the diagnoses by looking at the picture here? Yes? Who can answer this?
Placenta previa. C.
Yes, placenta previa and what else? Okay, no problem. Okay, because we are just going to start the topic, so it may be a bit difficult for you. So see here, this A, B, and C, which are part of the same spectrum of the problem, this is called abruptio placentae. Abruptio placentae. Here is a formation of retroplacental clot. This is a placenta here. This is a placenta, and there is a blood collection in between the placenta and the uterine surface. So this is called retroplacental clot, which is a very common phenomena in antepartum hemorrhage caused by abruptio placentae. So this is a concealed type of clot. Now this blood clot or bleeding has come outside, okay, and it has also come outside. Along with that, okay, there is a massive amount of hemorrhage. Now this one is called placenta previa. You're right, this is placenta previa. The insertion or implantation of the placenta is in the lower uterine segment, which is completely blocking the internal os. So these are a very good introductory slide for the discussion of late pregnancy bleeding. Now let's start. So definition of late pregnancy bleeding, also known as antepartum hemorrhage. Antepartum hemorrhage is vaginal bleeding occurring after 20 weeks of gestation. Now, let me write that synonymous term, also known as APH. APH or antepartum hemorrhage. Okay, antepartum hemorrhage. Antepartum means before the birth, especially in the third trimester, this type of things happen. Now, prevalence of late pregnancy bleeding or antepartum hemorrhage is less than 5% of the pregnancy, and these are the common etiology. See here, cervical, okay, cervical, see this, these are cervical erosion, polyp, and very rarely carcinoma. These are not related with pregnancy, but just like early trimester or early pregnancy hemorrhage, always the hemorrhage may not be related with the pregnancy. So this is one important conditions. Another is a vaginal conditions like varicosities and laceration. Varicosities and laceration of the vagina can also have late pregnancy bleeding that can happen as a complication or some of the features of pregnancy and during the examination or some surgery. Placental, which we are going to talk in detail in this class, like abruptio placentae, placenta previa, and vasa previa. Abruptio placentae, placenta previa, and vasa previa. So these are the important conditions of the placenta. One more, which is not mentioned here, but many students know it already, is uterine rupture. Uterine rupture also occurs in later part of the pregnancy, which can give rise to bleeding. Now, how we start the workup? Okay, how we start the workup or evaluating this type of patient. So, what are the patient's vital signs? We need to make sure the vital signs are stable, especially pulse and blood pressure. Okay, we should make sure they are stable because this is a case of bleeding. Okay, now I'm asking this question all the time when a case of bleeding comes. What happens to the pulse rate in case of hemorrhage? Yes? What happens to the pulse?
Hypovolemic.
Volumic side bleeding.
Lapsing pulse.
Very good. So there are two things happening. One, the volume of the pulse decreases. Pulse become feeble, okay, weak. And another one, the rate of the pulse increases. That is tachycardia. So tachycardia and low volume pulse. Now, related to the blood pressure, in the early cases of bleeding, blood pressure may still be normal, but if massive bleeding has occurred, then blood pressure will fall. Second, are fetal heart tones present or not? If the baby is still surviving inside the uterus or not? Very, very important question. Our whole management will differ according to the dead baby or the baby is still alive there. So absolutely important point. Now, I want to check whether you are revising your obstetrics or not. What are the different way by which we hear the fetal heart tone? Yes?
Stethoscope.
Doppler, sir, and stethoscope.
Stethoscope, sir.
Stethoscope, Doppler.
Very good.
By Doppler in early.
Very good. I already got the answer. Excellent. Students are saying Doppler and fetoscope. Wonderful. Doppler and fetoscope. These are the two very common way. Third one you can mention is your own stethoscope. Okay, the stethoscope which you are carrying with you, that can also be used to hear the fetal heart rate or fetal heart tone. Wonderful. Now, what is the status of the fetus inside? Okay, the same question again. Is the fetus compromised? Is the fetus heart rate is high, low? That means fetus is compromised. Fetus is under hypoxic state. This fetus is going to die very soon. So we want to be quite faster in our approach. Or is the condition of the fetus all right, so that I can even go for conservative management? Very important question. Another, what is the nature and duration of the bleeding? What is the nature and duration of the bleeding? Another important question we should ask to yourself as a doctor. Okay, if the duration of the bleeding is prolonged, then already the lady has lost a large amount of blood probably. If it has just happened, okay, I can evaluate, I can take some of my time and reach to the diagnosis correctly. Is there pain or contraction of the uterus or not? That means, okay, the uterus is trying to push the content downwards. Okay, that means she will be in labor very soon or already in labor. So these are the important questions. If there is no uterine contraction, she is not going to give birth very soon. Okay, so important knowledge. And then what is the location of placental implantation? Absolutely important. In placenta previa, it is present in the lower uterine segment, and in abruptio placentae, it is normally located in the upper uterine segment. So with this simple, question to yourself, you will try to find out where is placenta located or implanted, and you can find out the diagnosis here, the diagnosis of antepartum hemorrhage. Now, all the time we are mentioning the upper uterine segment and the lower uterine segment. So you may be wondering, what is the meaning of lower uterine segment? So listen carefully here. It is very easy answer. The lower uterine segment is the inactive part of the uterus. Okay, it is relatively thinner and it is a part of the birth canal. It doesn't take part in the proper uterine contraction. So in that area, if placenta is implanted, then it is called placenta previa. Now, what are the initial investigation and initial management you like to do in this type of situation? Now, see this investigation. CBC is always done to make sure, okay, what is the level of hemoglobin, what is the level of hematocrit, what is the amount of platelet. DIC workup is very, very necessary here, because sometimes the baby may be dead because of this problem, especially in abruptio placentae, because of the compression by that blood clot, because of the very severe separation of the placenta, the baby may die. So who knows, DIC is already there. Okay, so platelet, prothrombin time, partial thromboplastin time, fibrinogen level, and D-dimer assay has to be done to confirm DIC. Blood grouping and cross matching has to be done. The blood grouping is done every time when there is a case of hemorrhage. Now, one small practical information I like to share with you. Even if the lady say, doctor, I know my blood group, you don't trust that. Okay, that is fine. She remembers her blood group, but that is not reliable. You should do blood group in your own lab or in your own hospital. And according to the report, I should believe, yes, this is the blood group. Do not trust verbal answer. And what do you mean by cross match? Who can answer this? Cross match means what?
Sorry, we take blood of donor and recipient and we check their matching.
Very good. Excellent answer. This is. Yes. Yes, Vijay. Yes, continue.
So, sir, it is abnormal blood transfusion. Sir, when the two blood that are to be transfused are sort of the opposite blood groups.
Okay. Now see here, cross matching means, for example, that lady, okay, has presented with bleeding. Okay, that what we are talking now. This is a late pregnancy bleeding. Now we think, okay, we think she needs blood transfusion, but which blood group, okay, is appropriate for her? So what we do, we find a donor. We take RBC from the donor and we take plasma from the recipient. Then we match this together. If there is no reaction, then this blood is fit to be transfused. This is called cross matching. So RBC from the donor, plasma from the recipient. We match them together. If there is no reaction, this blood is fit for transfusion. Another is ultrasonogram for placental location. Always do, and never perform a digital or speculum examination until ultrasound study rules out placenta previa, because you may injure that placenta. With your examination, you may start hemorrhage there. So this is contraindicated until and unless you rule out placenta previa. Now, in any case of bleeding or hemorrhage, the first management is resuscitation. That is done by crystalloid or isotonic fluid. Okay, monitor urine output and then transfuse blood if that isotonic fluid is not enough. If fetal, okay, if fetal jeopardy is present, that means if there is a real danger to the life of the baby, if pregnancy cannot be continued because of high chance of fetal death, if you find fetal distress like fetal bradycardia or fetal tachycardia, then the fetus should be delivered as soon as possible, either by cesarean section or induction of the labor. Another important point, if the gestational age of the baby is around 36 weeks, means after the lung are matured, that can happen around 34 weeks. So after that, if this type of things occur, like antepartum hemorrhage by any cause, abruptio placentae, placenta previa, or vasa previa, or like that, then the baby should be delivered. But if the fetal jeopardy is not present, if a minor type of hemorrhage is occurring, and if the baby is not near the term, then conservative management has to be done. Okay, the pregnancy should be preserved or continued. So these are some of the very important points. What is abruptio placentae? Let's revise once again. This is normally implanted placenta which is separating way before its normal time. Placenta should separate only after the delivery of the baby. But in this condition, the baby is still there inside the uterine cavity, but placenta is prematurely separating, and that placenta is normally implanted. That means it is not present in lower uterine segment. It should be present in upper uterine segment. So this is called abruptio placentae. That separation can be partial or complete. Okay. It can be partial or complete. Okay, now see here. Now, complete separation is much more dangerous than the partial. It's quite easy to understand. Most commonly, bleeding is overt and external. Now, overt means, okay, obvious bleeding. That bleeding can be seen from outside because it is causing vaginal hemorrhage. So usually the bleeding is like that. But sometimes the bleeding may be internal. It is also known as concealed hemorrhage. Concealed means hidden, or internal hemorrhage. And if it happens, there is a big clot collection or clot formation behind the placenta. That's why it is known as retroplacental hematoma. Now everybody know the meaning of hematoma. It's a blood clot. Okay, so formation of blood clot behind the placenta is retroplacental hematoma. Now what it is doing there? Okay, think logically. This is a big blood clot. So this blood clot will give pressure to the baby. It will give pressure to the baby. Number one. So this will cause fetal hypoxia. Number two, that bleeding will also cause increase in uterine height, because this is extra mass there, right? So that mass will cause excessive fundal height over time, and this is painful conditions as well because uterus is contracting there. So all these things will make the diagnosis easier for us. Let's move on. Okay, now see here. Now, so you already know this is a dangerous situation for the baby. Now, what are the different types of abruptio placentae? So all of you, please focus on your screen. So there are three types which are very clearly shown. The first is called concealed type of abruptio placentae. The second is revealed type, and third is a mixed type. Now, concealed means hidden. Now see there, this blood clot is collected behind the placenta, but it has not come out from the vagina. That's why it is concealed. Revealed means it is dissecting the layer and then coming out of the vagina. So revealed means it is overt or obvious type of bleeding. And third is a mix. There is a big clot as well as some of the blood is coming out. So same thing is written here. Now, what are the clinical presentation of abruptio placentae? Means what happens to the lady? How do we diagnose? Okay, let's talk about that. Regarding the clinical presentation, the most common presentation is late trimester bleeding. Late trimester bleeding, and this abruptio placentae is the most common cause of late trimester bleeding as well. So you don't need to think otherwise. Just say this is the number one cause of late trimester bleeding. It is almost causing 1% of bleeding during pregnancies at term, and the most common cause of painful late trimester bleeding is also abruptio placentae. Because of that blood clot present behind the uterus will contract, and this leads to pain. So painful late trimester bleeding is abruptio placentae. So let me underline this for you. Very important point. Painful late trimester bleeding is abruptio placentae. Now, regarding the diagnosis, this is a type of presentation, isn't it? So we already got 1 point from the history. Second, during examination, you will find, okay, if the big blood clot is collected there, then the fundal height is slightly more than the normal. But if the blood clot is not collected, most of the bleeding is already coming out of the vagina, then the fundal height may also be normal. Third point, during ultrasonography, the placenta is normally implanted in the upper uterine segment, or in other words, it is not implanted in lower uterine segment. So these are the very important point for the diagnosis. Okay, So let's move on. Now, there is a small classification of abruptio placentae. It depends on the severity. So mild abruption, moderate abruption, okay, and severe abruption. So let's talk about them one after other. Mild abruption means the vaginal bleeding is minimal, okay. There is no fetal monitor abnormality, means fetus is still not that harmed. The fetal jeopardy has not still occurred. There is no abnormality in fetal heart rate, either decrease or increase. That's the meaning. There is localized uterine pain and tenderness. Localized means in that area only where there is a collection of clot, and there is incomplete relaxation between the contraction. So these are features of mild abruption. And in case of mild abruption, if the baby is very premature, then the pregnancy should be continued. There is no real danger to the baby, right? So you do not need to deliver the baby quickly, especially if the baby is premature. But if the baby is already full term, then no need to keep the baby inside. So we need to decide accordingly. The second one is a moderate abruption. Now see there are symptoms of uterine pain, important point. There is moderate vaginal bleeding now. It can be gradual or abrupt in onset. Now this bleeding is more than the mild abruption, and in this condition around 25 to 50% of the placental surface is already separated from the uterine cavity. So around half of the placenta is already separated from there. And very, very important point is there is some problem to the baby now. Now see here, the fetal monitoring may show tachycardia or mild late deceleration. This mild late deceleration means now the baby is going towards bradycardia as well. Now bradycardia is always more dangerous than tachycardia. Remember this. Only bradycardia occurs only when there is severe, compression or severe hypoxia to the baby. Now the last one is a severe abruption. In this condition, the symptoms are usually abrupt, okay. There is a continuous knife-like uterine pain because the condition is severe, so the pain is also continuous, and definitely more than 50% of the placental separation occurs. Sometimes even 80 or 90% of the separation occurs in this case, and there is a real danger to the baby. It will show severe late deceleration, means it is going towards fetal bradycardia, and bradycardia can also already occur, okay, which is shown in the fetal monitor, or when you examine the fetal heart rate by fetoscope or your own stethoscope or by Doppler, you note that the fetal heart rate is less than 120 or even less than 100, and the fetus may already be dead there because of severe compression. So these are absolutely important point in severe abruptio placentae. Now you already know this point. DIC can occur in case of abruptio placentae. So who knows, it has already occurred, and once DIC occur, it is very difficult to manage. Ultrasound will confirm, it will show you the deposition or collection of retroplacental clot. Okay, sometimes it is a mixed type of abruption. The clot may not be big, a lot of blood has already come out, so different types are there. So mild abruption, moderate abruption, and severe abruption. So let's move on. Now all of you have a look here. What are the risk factors for abruptio placentae? Means which type of pregnancy will develop it? Isn't it? That question should come in your mind. Now let's have a look here. Abruptio placentae occurs more commonly with previous abruption. For example, this lady is parity 2, okay, or parity 3, and in the earlier pregnancy she already suffered from abruptio placentae. So in this pregnancy also there is a high risk. That is one point. Another is pregnancy induced hypertension or chronic hypertension in that female or lady, and maternal trauma. The trauma, okay, should occur in the abdomen, and that trauma may cause separation or premature separation of the placenta. So these are some of more common risk factor. Apart from them, maternal cocaine abuse is another one. Now, what is cocaine? Yes, guys, what is cocaine?
Sir, like
Yes.
It is a drug in a powder form.
Okay, it is a drug in a powder form.
sir, it is actually or snorted.
Okay, it can be sniffed. Okay, it can be sniffed. And remember, this cocaine is very commonly abused drug all over the world. It's one of the important type of drug abuse or form of drug abuse, I should say. And another very important point from the pharmacology, this is a type of local anesthetic. Cocaine, lidocaine, bupivacaine, xylocaine, all the are different types of local anesthetic, but it is rarely used as a local anesthetic drug. Okay, rarely. We have some other wonderful drugs for that, but this is also a type of sympathomimetic agent. It will cause increase in blood pressure in that person who is taking it. Now, in this condition also, probably the excessive rise in blood pressure leading to hypertension is responsible for abruptio placentae after cocaine abuse. Another one is premature membrane rupture. Premature rupture of membrane, PROM, is also associated with abruptio placentae. Now we know most of the things about it. Now let's talk about the management. How we are going to manage this type of case. Now see here, there are two things which I like to highlight right in the beginning, and those two things are, let me explain, okay, with the help of annotation here. You see this, okay, listen carefully. Those two things which are very important regarding the management are, what is the status of the baby? Number one, is the baby still surviving there, or is the baby already dead? That's the first point. And the second is, still if the baby is surviving, what is the condition? Is the baby is already jeopardized there? For example, is there fetal tachycardia or bradycardia present? And if fetal tachycardia or bradycardia is there, we don't, okay, delay the delivery process. We have to be quite fast in the delivery of the baby, otherwise we may lose the baby. This is number one thing. Number two, what is the gestational age? What is the gestational age? Is the baby already mature, or is the baby very premature? If the baby is mature or about to mature after 34 weeks, okay, it is safe to deliver the baby because the lungs are already matured. But before 34 weeks, the baby's lungs are still immature. There is no surfactant development. So the baby will suffer from breathing difficulty if we deliver the baby. Having said that, it depends on, okay, other points also. For example, if there is real danger to the life of the baby by massive type of abruptio placentae, then that time we don't even consider the gestational age. We deliver the baby and we manage the baby as a premature baby. So these are very, very important point. And third point here is, what is the hemodynamic status in the mother? See here, hemodynamic status means whether the mother is in shock or not, whether the mother is having DIC or not. So all these points are necessary for the management. Now let's come to the slide here. So one type of management is emergency cesarean section. Now in which case we have to go for cesarean section. See here, this is performed if maternal or fetal jeopardy is present as soon as the mother is stabilized. So let's say the mother was having hemorrhagic shock. You first resuscitate the mother. You give a lot of isotonic fluid and then blood. Bring that blood pressure back to the normal. Okay. Then only take the mother for cesarean section. Otherwise, there is high chance of death during cesarean section. Second point is fetal jeopardy. Okay. If the fetus is already dead, you don't do cesarean section during that time. You allow the baby to deliver by vaginal route. So these are the important points. Now, second way of delivery is a vaginal delivery, and this is performed if bleeding is heavy but controlled, or if pregnancy is beyond 36 weeks, means relatively nearing to the full-term baby. And even if the baby is premature, after 34 weeks, there is no real danger to the baby, I already told you. So vaginal delivery is preferred. Now, during this time, even if the lady is not in labor, you induce the labor by performing amniotomy. Now, amniotomy means, okay, you do rupture of the membrane by yourself. It is called artificial rupture of membrane. It is one of the way of induction of the labor. There are different advantages of this, okay? There are different advantages of this, and one of the important advantages apart from inducing labor is you also can see what is the color of the amniotic fluid. Now, probably you already know this point. If the amniotic fluid color is greenish, that means the baby has already passed meconium inside the uterine cavity. In other words, the baby is already having fetal distress. This is the feature of fetal hypoxia. Now, another is place the external monitor to assess the fetal heart rate pattern and contraction, just to make sure what is the fetal heart tone there. If it is in the upper range or the lower range, is there any fetal deceleration or not? Fetal heart rate deceleration, I should say, or either is there proven bradycardia or not. So all these things can be done, okay, by monitoring, and that should be done before vaginal delivery. Avoid cesarean section if the fetus is dead. Do not give scar to the uterus after the death of the baby. This is not really necessary. You can deliver the baby by vaginal route. Okay, there is no real, you don't need to hurry, isn't it? You have a lot of time after the baby is dead. But I'm not saying you deliver the baby after many days or many weeks, okay? During that time, there is a danger of DIC. I'm saying you don't need to deliver in minutes or hours. You can deliver in few days as well. So this is important point. Now, what are the conservative in-hospital observation we should do in abruptio placentae? Let's talk about it. This is performed if mother and fetus are stable and remote from the term. Now, what do you mean by this? There is no real danger to the life of the mother and fetus, as well as the baby is premature. If the bleeding is minimal or decreasing, and if the contractions are subsiding, means they are not increasing one after other, okay, they occur here and there. In this type of situation, you admit the lady in the hospital and just observe. You don't deliver the baby quickly. So these are the important points. Confirm the normal placental implantation with ultrasonography. Don't mistaken abruptio placenta for placenta previa. So ultrasonography examination is always done, and replace the blood loss with crystalloid and blood products as necessary. As necessary. In the beginning, you always start with crystalloid. What are the examples of crystalloid, guys? Yes? What are the crystalloid? Who can answer that to me?
Sir,
Yes,
0.9% solution, sir.
good. Then Now see here, so he's right. This is 0.9% normal saline, or you can simply say normal saline. Normal saline means it is 0.9% and lactated ringer, or you can also call it ringer lactate. These are the two very commonly used crystalloid in the hospital. Okay, never forget them. We always start with this type of fluid, and later on, if there is excessive blood loss, we'll replace the blood. So these are called conservative in hospital observation as well as management. Now, what are the complications of abruptio placentae? So what can happen to the baby as well as mother? Now, mother will suffer from hemorrhagic shock. This hemorrhagic shock occurs because of excessive hemorrhage. Very easy explanation. Another, acute tubular necrosis. What is acute tubular necrosis? I want quick answer here. What is ATN?
So due to hypoxia, there is a necrosis of the there is a tubular network of nephron in the kidney.
That it is the death of the tubular epithelial cell from the renal tubule of the kidney, sir. Necrosis of the.
Okay, so both of them are answering excellently. Okay, so this is a type of renal failure. This is intrinsic type of renal failure, where because of prolonged bleeding, the lady has suffered from hemorrhagic shock. Means hypotension is already there. There is decreased kidney perfusion, and this will lead to hypoxia to those renal tubules. Okay, those tubules in the kidney, in the nephron. Now this is called acute tubular necrosis. Remember, this is called acute renal failure. So the lady has already suffered from this. Third important complication is DIC. Many times we talked about this. This DIC is an important complication, and it occurs from the release of tissue thromboplastin into the general circulation, and this occurs from the disruption of the placenta. So DIC, and the manifestations of DIC would be there is bleeding, okay, from different site of the mother, as well as clot formation and blocking of microcirculation in different parts of the body. Another type of complication is called cuvellar uterus. Okay, cuvellar uterus. What do you mean by that? It refers to blood extravasating between the myometrial fiber, okay, which appear like bruises on the serosal surface. Sometimes the blood may reach to the peritoneal cavity as well. So let me explain this in an easy way. See here, what is happening? Abruptio placentae means there is a collection of blood clot behind the placenta, means in between the placenta and the uterine wall. If that blood is under a lot of pressure, that blood can extravasate between the myometrial fiber, meaning it is going inside the wall of the uterus, okay, and it may even reach to the serosal surface. In very severe situation, the blood may even reach to the peritoneal cavity by crossing the serosa. So this is a serious situation. This is known as cuvellar uterus, and it is also known as utero-placental apoplexy. This is just another term. This occurs in severe type of abruptio placentae. Okay. Now, with this information, okay, let's go and talk about placenta previa. The placenta previa is another very common cause of late pregnancy bleeding, especially in the third trimester. Every student know it already. Placenta previa means it is inserted or implanted in the lower uterine segment. This is the meaning. And what is the danger of this? It may obstruct the delivery of the baby. It may obstruct the natural passage of the baby through the vaginal route. And during that time, a lot of bleeding may also happen. This is common early in the pregnancy, but is most often not associated with bleeding, because after the uterus gradually enlarges, even if the placenta is separated towards the lower segment, it may pulled upwards later on. So when the mother, okay, reaches term in the later part of the pregnancy, I mean, then the placenta may be present in the normal location. At term, the placenta previa is found in only 0.5% of the pregnancy. So it is not that very common. And the important point regarding the diagnosis is it leads to painless vaginal bleeding at the 3rd trimester. This bleeding is painless, whereas in abruptio placentae, it leads to painful vaginal bleeding. This is the important point. Now, why there occurs bleeding? This occurs because of avulsion or separation of the anchoring villi of an abnormally implanted placenta at the lower uterine segment, because it got stretched. Okay, lower uterine segment got stretched and thinner in the later half of the pregnancy, and that can simply cause separation of the anchoring villi, which leads to hemorrhage. So this is how hemorrhage occurs in placenta previa. Okay, so we are talking about placenta previa. So before the break, you know what's the meaning of placenta previa. Now let's look at the picture. Now see here very carefully, all of you. This is a normal placental attachment here. So see this, there is a baby inside the uterine cavity. This is the umbilical cord, you can clearly see it. And this is the placenta. One end of the umbilical cord is attached to the placenta, another end to the baby. Now this is the placenta. It is attached on the upper uterine segment, or you can also say attached at the fundus and body of the uterus. Okay, so this is the normal. Now in this case, look at the attachment of the placenta. See here, it is present in the lower uterine segment. Now the question should come in your mind, what is lower uterine segment, by the way? So please see here, look here carefully. You can see a slight constricted part here, a slight type of constriction here, okay, like exactly here, to be very precise, this one. Okay, from this area till the internal os. Internal os means inner opening of the cervical canal. This is called lower uterine segment, and this lower uterine segment is very thinner in comparison to the upper uterine segment. And one another point, it will also stretch or dilate during the labor. It will stretch or dilate during the labor, and it is thinner in comparison to the upper uterine segment. So this is the lower uterine segment. So placenta previa means when it is attached, okay, on the lower uterine segment. Now let's move on. Now how to make a diagnosis of placenta previa? Now, see there, one point is in the history. There is the presence of painless late trimester vaginal bleeding. This is a painless vaginal bleeding, and sometimes the bleeding is minimal, sometimes it may be massive, which is confirmed by obstetric ultrasound, and that ultrasound should show the implantation or attachment of the placenta in the lower uterine segment. Then the diagnosis is confirmed. Now let's classify placenta previa. What are the different types? Okay, they are classified under total, complete, or central placenta previa, partial placenta previa, or marginal or low-lying placenta previa. Now let's elaborate on them. Total, complete, or central previa means the placenta completely covers the internal cervical os. Now what do you mean by that? Okay, cervix is a canal-like structure. It has got two openings. One is external os, another is internal os, and through the internal os, the cervical canal opens into the uterine cavity. So in this type of placenta previa, the placenta completely covers the internal os, and this is a very dangerous type of situation because it is not leaving any space there for the passage of the baby. When the labor pain starts, when the uterus is vigorously contracting, there may be severe hemorrhage. Second type is a partial placenta previa. In this condition, the placenta partially covers the internal os, partially covered, not completely covering. And third is marginal or low-lying previa. Here, the placental edge is near but not over the internal os. It is near, it is not touching the internal os. So these are the different types of classification. Now, another type is also mentioned there, okay, a bit similar to the type which we just highlighted. First, second, third, and fourth, also known as type 1, type 2, type 3, and type 4 placenta previa. So let's elaborate on them. Type 1 is a major, the major part of placenta in type 1 lies at upper segment, and only a lower margin of that placenta is just reaching the lower segment. It is not touching or not very near to the internal os. It is just reaching the lower uterine segment. So this is known as minor type of placenta previa. So less dangerous to the pregnant woman. Second type, or type 2, it reaches the internal os but doesn't cover it, just reaches there. Third, or type 3, it partially crosses the os. Okay, it partially crosses the os or partially covers the os. Now the important point is it covers the internal os when the internal os is closed, but it doesn't entirely do so when it is fully dilated. Remember one point, during delivery or the process of labor, during the first stage of the labor, the cervix is dilated up to 10 centimeter. So during that time, this type 3 placenta previa also will not completely cover the internal os, but when it is closed, then it will cover. The most complicated type is type 4. In this situation, the placenta completely crossing the internal os. So we can say type 1 and type 2 are called minor placenta previa, and type 3 and type 4 are called major placenta previa. Now why the term major? Because it is complicated situation. It may lead to more hemorrhage. Now all of you, please focus on the screen. These pictures are highly informative. So this is called low-lying placenta. Okay, low-lying placenta or type 1 placenta previa. So see, this is the internal os. Okay, this is the cervical canal. So internal os is right here. So it is not even near to the internal os, but it is definitely in the lower uterine segment. So this is low-lying placenta, a type 1 placenta previa. This is type 2. Okay, the marginal one, just touching the internal os. See that it is not covering, it is just touching it. Type 3 are partial coverage of the internal os. See, partial coverage of the internal os. Now let me elaborate on this. When the internal os is closed, means the lady is not in labor, probably it is covering the internal os, but when it is dilated, then it will not cover it completely. And type 4, see there, it is complete coverage. The placenta itself is located horizontally over the internal os. So this type 3 and type 4 are called major placenta previa. Type 1 and type 2 are called minor. So how the lady presents to the hospital? What are the clinical presentation of placenta previa? Many of the point you already know now. The classical clinical picture is painless late pregnancy bleeding. In the third trimester, okay, she complains of bleeding, but that is painless. That bleeding can occur during rest or activity. Suddenly and even without any warning. So these are the important points. That bleeding may be preceded by trauma, coitus or sexual intercourse, or during pelvic examination. These are some of the precipitating factor for bleeding in case of placenta previa. Now remember, placenta is located there in the lower uterine segment, right? So the bleeding may be precipitated by trauma, sometimes by sexual intercourse, or sometimes during pelvic examination. That's why in the previous slide I clearly mentioned, do not do per vaginal examination or digital examination in case of third trimester bleeding. Who knows, this may be a case of placenta previa, and your finger will further damage the low-lying placenta, and it can convert into major type of hemorrhage. And don't do any speculum examination if you suspect that. Rule it out by doing ultrasound exam. Make sure there is no placenta previa, then those type of examinations can be done. So these are very important point. One more, the uterus is non-tender and non-irritable. Now this point is important if you want to differentiate between abruptio placentae and placenta previa. In abruptio placentae, uterus is usually tender, okay, and non-irritable means the uterus is not contracting. In abruptio placentae, the uterus is contracting, and because of that contraction, probably it is painful. Now, another point, what is the risk factor of placenta previa? Which type of lady, okay, commonly develops placenta previa? These are the risk factor. Previous placenta previa, same like abruptio placentae. In that case also, if previous history of abruptio placentae was there, there is a more risk. Multiple gestation, okay, multiple gestation, multiparity, and advanced maternal age. Multiple gestation means, okay, twins, triplets, quadruplets, there is more risk. Multiparity, this multiparous lady, okay, like P2, P3, P4, P5, these are multiparous. And advanced maternal age, these are the risk factor for placenta previa. Now, the important part is the management, okay. Now, you already got that concept, how to manage late pregnancy hemorrhage. Now, this discussion will be very easy for you. One of the modality is emergency cesarean section. Now, remember one thing, we only go for emergency cesarean section if there is some big problem to the mother or the fetus. That is the meaning of maternal or fetal jeopardy. If it is present, then only we go for emergency cesarean section, okay. And please take that mother to the operation theater only after stabilizing her. That means if her vital signs are altered, okay, bring them back to the normal, especially the blood pressure and the pulse. Conservative in-hospital observation is another way of management, and this is done by advising bed rest. This is done by advising bed rest, okay, and this is especially done if the baby is still premature, before 34 weeks of the gestation, and if both of them are stable, okay, and remote from the term. Remote from the term means if the baby is still premature. Now, why I am still mentioning 34 weeks rather than 36 weeks? Because before 36 weeks is also preterm, isn't it? But why I am continuously mentioning 34 weeks here? Any answer? Anybody?
Because she must be term.
As the fetal lungs develop.
Now, this may be a bit of a difficult question for you probably. So all of you, please listen here. Why I am mentioning 34 weeks is at 34 weeks of gestation, the lung maturity of the fetus occur. the surfactant is developed at 34 weeks, or it is formed at 34 weeks. So even after that, okay, I mean, if the baby is delivered after 34 weeks, the baby is relatively safe. Though the baby is still premature, there is very less chance of respiratory distress in the newborn. But before 34 week, there are so many problems. One, the baby is a bit premature. Second, the baby will have difficulty to breathe as well. So that's why the 34 weeks of gestation is a very important landmark, okay, for the newborn baby. Now, this conservative in hospital observation is done if the initial bleeding is not severe. You already know this point. If it is severe, we need to go for emergency cesarean section. Confirm abnormal placental implantation with ultrasonography and replace blood loss with crystalloid and blood products as needed. It is same as the management of abruptio placentae. In that situation also we do this type of management, but remember, mother and fetus should be stable, okay, and the baby should be not near the term. The baby should be premature. Let's move on now. Okay, now one of the modality of the delivery is vaginal delivery. So this may be attempted if the lower placental age is more than 2 centimeter from the internal cervical os. You can try for the vaginal delivery because the placental age is still a bit far away from the internal os of the cervix, and there is a less chance of damage or rupture of the placenta. Another is scheduled cesarean delivery. Okay, this is scheduled cesarean delivery, means planned type of cesarean section. This is known as elective cesarean section, not the emergency one. And this is performed if the mother has been stable after fetal lung maturity has been confirmed by amniocentesis, usually around 36 weeks of gestation. After 34 weeks, the fetal lung will mature, which is already confirmed by amniocentesis. So after that, okay, we can go for elective cesarean delivery for the baby. Now, what is amniocentesis? Who can answer that? Amniocentesis means what? Anybody?
Sir, it's an examination of a amniotic fluid.
You are right. Absolutely. This is
Sterility procedure in which the amniotic fluid is removed from the uterus.
okay. Absolutely correct. This is aspiration of amniotic fluid and examining it. Remember, centesis means aspiration. Now, there are similar type of terms in clinical medicine like thoracocentesis, okay, thoracocentesis, pericardiocentesis. These are, aspiration of the fluid from the pleural cavity and pericardial cavity. So same like amniocentesis means aspiration of amniotic fluid from the uterine cavity. Now, what complication can occur in a case of placenta previa? Let's talk about that. If there is a previous uterine scar, then the villi may invade into the myometrium, which results in placenta accreta. Long time ago, when we talk about the class on placenta, we talk about different complications of the placental insertion, like placenta accreta, placenta increta, and placenta percreta. Now, these are, okay, insertion of the placenta into the substance of the uterine wall. Now, accreta means it is just going inside. Okay, so this is a type of complication. And what is the danger of this now? This can result in intractable bleeding requiring caesarean hysterectomy. Now, let me explain this point for you. Now, see here. intractable bleeding, means very difficult to control, requiring cesarean hysterectomy. Now, we probably do not know this placenta accreta in the beginning. So probably that placenta previa is a very severe one, okay, the major type. So we have delivered the baby by cesarean section, but during the delivery of the baby or during the operation or surgery, the surgeon have found that, okay, placenta has gone inside the substance of myometrium, and it will cause, or it is causing, very severe type of bleeding. So just to save the life of that lady from postpartum hemorrhage, they go for hysterectomy. This is removal of the uterus. This is a major decision. Let me tell you again, this is a major decision. As far as possible, we always want to preserve the uterus there. But if there is a danger to the life, because we cannot control that bleeding from any other means, then hysterectomy has to be done. Another also term which is known as Sheehan syndrome. You already know this. Sheehan syndrome occurs because of profound hypotension or profound hemorrhage occurs after the delivery. As a result of this, okay, there is relative ischemia of the anterior pituitary gland, because during pregnancy, the pituitary gland is hypertrophied. It is much larger than the normal. So there is relative ischemia, and that relative ischemia leads to necrosis. This is known as Sheehan syndrome. Sheehan syndrome. Never forget this. Very important question in many MCQ question and clinical problem solving question in the exam. It can also result in acute tubular necrosis. This is renal failure. The mechanism is same. If there is decreased blood perfusion to the kidney, kidney can fail, and if there is decreased blood perfusion of the pituitary gland, it can get necrosis, which is called Sheehan syndrome. Now, what are the hormones? Exactly. What are the hormones released by anterior pituitary? Who can answer this to me? Hormone coming from anterior pituitary. Yes, please go on.
So we've got the prolactin, the growth hormone, the adrenocorticotropic hormone, luteinizing hormone, sir, thyroid stimulating hormone.
Very good, very good. I'm sure not only Uzair, many other students also know this. This is an extremely easy question for you. Hormone released by anterior pituitary. Growth hormone, okay? Prolactin, TSH, thyroid stimulating hormone, ACTH, adrenocorticotropic hormone, LH and FSH, luteinizing hormone and follicle stimulating hormone. Now, if pituitary gland is necrosed, then what will happen now? The level of all these hormones will be reduced, leading to a lot of other problem in the mother. Now, let's move on. After going through abruptio placentae and placenta previa, the third type of the condition which can cause antepartum hemorrhage or late pregnancy bleeding is Vasa previa. Now, what is this Vasa previa and what are the important points? Let's go through it. Vasa previa is present when fetal blood vessels traverse the fetal membrane over the internal cervical os. Now, this is not a very common condition. Now, in this condition, there are few criteria which are necessary. One, the fetal blood vessels should pass through the fetal membrane and they should cross the internal cervical os, and then only there is the placenta. Now, if that is happening when the fetus is descending downwards during labor or delivery, it will tear those traversing blood vessels, which can lead to serious hemorrhage. Now, one big difference between the hemorrhage in placenta previa and abruptio placentae and this condition is, in this condition, the bleeding is coming from the baby. It is coming from the baby side. But in those two conditions, the bleeding is coming from the mother side. That's why even a slight amount of hemorrhage in vasa previa can be very lethal to the baby, and it can easily lead to fetal death. Now remember, how much blood is present in that fetal body probably? Yes? Who can answer this to me? How much blood is present in our body? Probably I have explained this before to you.
5 liters.
Sir, 4.8 to 5 liter in our body.
5 liters.
Good, but is that amount present in the fetus? No, right? No. So
Sir.
there is other way of answering. So you can simply remember it is around 8% of the body weight. 8% of the body weight. Now let's talk about, let's say the weight of that fetus is 3 kg. 3 kg, okay, is isn't it 3 liter of the blood? So what is 8% of the 3 liter? Can you calculate it? Yes, please. Who can do that quickly?
0.24. 0.24.
Now let me write here. Maybe you have not listened properly. See this, 8% of 3000 ml equivalent to how much? That is the question.
That is 240, sir.
240 ml. Now see here, what I am trying to explain here. Only 240 ml of blood is present in that fetus body. So even a slight amount of bleeding occurring from that fetal body would be detrimental to the health of that fetus. The fetal may die easily. This is called fetal exsanguination. Means all the blood may be, coming out from the body very easily in case of vasa previa. Whereas in placenta previa and abruptio placentae, the bleeding is coming from the placenta, that is from the mother side. So they are relatively less harmful in comparison to the vasa previa. These blood vessels, they may be from either a velamentous insertion of the umbilical cord or maybe joining an accessory which is known as succenturiate placental lobe to the main disc of the placenta. Now, if you again recall your memory, the succenturiate lobe we have already discussed before. This is one extra lobe of the placenta which is inserted a little bit far away from the main placenta. So it is one extra piece of the placental tissue somewhere, and it is connected with a blood vessel definitely. Okay, so this is the meaning. And velamentous insertion of the umbilical cord means it is not really inserted in the main substance of the placenta. Rather, it is inserted into a fetal membrane, and that fetal membrane insertion can lead to passage of the fetal blood vessels through that membrane, and then only there is the main placenta. If that happen in front of the internal os, this is called vasa previa. So you need to remember these two important terms here: velamentous insertion of the umbilical cord and succenturiate placental lobe. These are very important risk factor for vasa previa. Now all of you have a look here. Look at this picture. Okay, so let me explain this with the help of pointer. So see that this is a placenta. Okay, this is placenta. This is called fetal membrane. This outer, shining membrane is a fetal membrane, amnion and chorion. So see this. This is umbilical cord. You can clearly see it. Look at the insertion of the umbilical cord here. It is not inserted into the main substance, okay, of the placenta. Rather, it is inserted into a fetal membrane, and then it is divided into different blood vessels, and these blood vessels pass certain distance into that membrane, and then only there is the placenta. So this type is called velamentous insertion of the umbilical cord. Velamentous insertion of umbilical cord, which can easily give rise to vasa previa and hemorrhage. Now This is a schematic diagram. Okay, let me explain this once again for you. See this. This is a placenta here. This is umbilical cord. Okay, look how well the umbilical cord is inserted on the placental tissue. Right at the bulk of the placenta it is inserted. But in this condition, see here, okay, this is umbilical cord here. Here is placenta. So it is inserted a little bit far away from the main placenta into the fetal membrane, and through that membrane it is reaching the placenta. And there is an internal os. Okay, so it is also traversing the internal os, and this is called a Vasa Previa. Very high chance of hemorrhage during third trimester. Another picture, okay, is about accessory lobe of the placenta or succenturiate lobe of the placenta. Now this is the succenturiate lobe. See this. This is the one. This is the main substance of the placenta, and there is a big gap here. This lobe is not attached to the main part of the placenta. There is a gap. That's why it is called accessory lobe. Now look at here. These are the blood vessels which are going. So if these blood vessels traverse in front of the internal os, they can also bleed during the late pregnancy, resulting in Vasa Previa. Now how to reach to the diagnosis? See here. How to reach to the diagnosis? This is rarely confirmed before delivery. This is important point, but may be suspected when antenatal ultrasonography with color flow Doppler reveals a blood vessel crossing the membrane over the internal cervical os. This is called Vasa Previa, but it is difficult to find out during antenatal ultrasonography. A very good ultrasonologist can detect it even if he examines it very carefully. Okay, he or she examines it very carefully. The diagnosis is usually confirmed after the delivery on examination of the placenta and fetal membrane. But remember, the baby is already very badly affected. Okay, if we rely on this type of diagnosis, because the bleeding has already occurred, isn't it? You till now you have not yet diagnosed it. Okay, so that can be detrimental to the life of the baby. Let's move on. The clinical presentation of Vasa Previa. These are the classical triad. One is rupture of the membrane. Another is painless vaginal bleeding, and third is a fetal bradycardia. Rupture of the membrane has to occur because these blood vessels are passing through those membrane in front of the internal os, so they can bleed very commonly after the rupture of the membrane. First point. Second, the type of bleeding is a painless vaginal bleeding, just like placenta previa. And third is a fetal bradycardia. Now, can anybody tell me why there is fetal bradycardia in this case? Yes? Why? Say it again. Okay, so now he's right. Actually, fetal bradycardia occurs because of severe loss of the blood from the baby side. In the beginning,
So there is also compression of the fetal blood vessels. So this can also be a reason in that.
okay, so remember, in the beginning, there is fetal tachycardia, but I already told you this Vasa Previa is a very severe type of hemorrhage. If it occurs, it will quickly exsanguinate the baby. And by the time we diagnose, the baby may already be in bradycardia stage. The heart rate is less than 100, and that is a very serious situation. We need to deliver the baby as soon as possible to save the life. So even if you say fetal tachycardia right in the beginning, you are not incorrect, but that is very difficult to diagnose. By the time we diagnose, the baby is already in bradycardic phase. This is because of severe type of hemorrhage in case of decompensation stage. Now, some of the risk factors for Vasa previa: filamentous insertion of the umbilical cord. Every student know that now. Accessory placental lobe, which is called succenturiate lobe of the placenta, and multiple gestation. Multiple gestation. There may be more than one placenta sometimes in a multiple gestation. It depends on what type of multiple gestation we are talking about. So that is a risk factor. And management, okay, we have to deliver the baby immediately. There is not even few minutes time here. This is much more serious in comparison to placenta previa and abruptio placentae. So immediate cesarean delivery of the fetus is essential, or the fetus will die from hypovolemia. Now, before I stop this class, let me ask this question again: why there is high chance of fetal hypovolemia in this case? Why? Yes, guys.
Severe loss of blood from fetus.
Severe hemorrhage.
Good. Okay, very easy question, because in this condition the blood directly is getting lost from the fetal circulation. It is not because of the maternal circulation. In abruptio placentae and placenta previa, it occurs from the maternal circulation. So whatever problem occurs, it is to the mother first, and after that the baby will suffer secondarily. But in this case, everything is getting lost from the baby. So there is a very high chance of death from the hypovolemia of the baby. Okay, so there is one more cause of antepartum hemorrhage or late pregnancy bleeding, which is not as important as other from the exam point of view, but from the practical point of view, it is very, very important. That is uterine rupture. Fortunately, it is not very common. Uterine rupture. So let's talk about this before I move on to the labor and its diagnosis. Now, the definition of uterine rupture is complete separation of the wall of the pregnant uterus with or without expulsion of the fetus that endangers the life of the mother or the fetus or both of them. Let me explain this in a very easy way. Rupture of the uterus means there is complete tear of the walls of the uterus. This is a pregnancy we are talking about, and during the pregnancy there is a baby developing inside the uterus. So after the rupture of the uterus, there is severe chance of hemorrhage. That hemorrhage can endanger the life of the mother, or that rupture can endanger the life of the baby as well. The rupture may be incomplete or complete. Okay, incomplete means it doesn't include the peritoneum, and complete means it includes the visceral peritoneum as well. Now, how many layers are there in uterus? Tell me, what are the layers of the uterus? Yes?
Following three layers:
Yes?
endometrium, myometrium, perimetrium.
Very
And
good.
endometrium has further three layers: compact layer, spongy layer, and basal layer.
Okay, fine. Very good answer. Okay, many students know that. So uterus has got three layers: endometrium, myometrium, and perimetrium. Okay, this much is enough, very easy. Endometrium, myometrium, and perimetrium. Now remember the outermost layer, okay, the perimetrium, and it is covered by peritoneum. Especially most of the part of the uterus is covered by peritoneum. If that rupture include that peritoneum as well, then it is a complete rupture. Otherwise, it is incomplete. Now, what are the clinical presentation, okay, of uterine rupture? One of the presentation is vaginal bleeding. That's what we are including this under antepartum hemorrhage topic. Another one, severe abdominal pain. Third, there is alteration in uterine contractility because of the turn or tear of the uterus. Uterus is torn, there is a rupture, the walls have completely given away. So as a result of this, the uterine contractility is altered. It doesn't or cannot produce a very good contraction. On the other hand, if we feel for or listen for the fetal heart rate, sometimes the fetal heart is not found, means the baby is already dead. Sometimes it is tachycardic, or sometimes it may be bradycardic as well. The rupture may occur before the labor or during the labor. Okay, in both conditions, the rupture can happen. If it occurs before the labor, the lady will come with antepartum hemorrhage. That's why our topic is covering now. But it can occur during the labor as well. Let's move further. How to diagnose it? Diagnosis is confirmed by surgical exploration of the uterus, but it can be suspected by those clinical features which we just discussed. Okay, but confirmation is done by surgical exploration, and during that time we can see rupture of the uterine wall, or sometimes a part of the baby is coming out, or whole baby is lying in the abdominal cavity also. Regarding the risk factor, the most common risk factors of uterine rupture are previous classical uterine incision, myomectomy, and excessive oxytocin stimulation. Now, the previous classical uterine incision means these days, okay, for the cesarean section, do you know where we give the incision? Any idea? Where in the uterus we give the incision? Anyone? Maybe you have not, gone through this. This is a special topic which.
Sir, below the
Yes, please.
Fundus.
below the umbilical.
Okay. Yes. Now listen here. Okay, this is a bit difficult question, so let me explain this for you. These days we call it lower segment caesarean section, LSCS, lower segment caesarean section. That means the incision on the surface of the uterus is given on the lower uterine segment. Now in the morning class I explained about the lower uterine segment. Okay, it is the lower part of the uterus, and during the labor this lower uterine segment will be stretched and dilate, whereas the upper uterine segment will contract vigorously, and it is much thicker also. So we give incision to the lower uterine segment. That's why it is called LSCS these days. But previously, in the earlier years, they used to give a bit of vertical incision on the uterus to take out the baby, and that was associated with high chance of uterine rupture. That is called classical uterine incision. Myomectomy is a removal of myoma, and remember, myoma are benign tumor which develops from the uterus, and these tumors are also known as leiomyoma. So removal of leiomyoma or myoma is called myomectomy. So after that surgery, the uterus will become thinner and weaker. Another risk factor may be excessive oxytocin stimulation. Now what oxytocin does to the uterus? Yes, what is the effect of oxytocin?
Dilation.
Contraction.
Exactly, it contracts the uterus. Okay, oxytocin is exactly it leads to contraction of the uterus along with prostaglandin, definitely. So if you give a lot of oxytocin, if that oxytocin excessively stimulates the uterus, there is a chance of uterine rupture, especially if there is already a scar on the uterus. So that is always a risk factor. And other risk factors are grand multiparity and marked uterine distension. Now grand multiparity, okay, she has given birth to the many baby, so already uterus is thinner and weaker. On the other hand, marked uterine distension means uterus is very big, okay, it is markedly distended, there is a chance of rupture. Now there is one important point, please pay attention. A vertical fundal uterine scar is 20 times more likely to rupture than a low segment incision. That's what we were talking just now. These days, we give lower segment, okay, incision. Means incision is given in the lower uterine segment. And remember, this is a thinner and it is a stretchable part. But the upper uterine segment is very thick and it is a contractile part. So somehow if they have given incision there, you know, that part will become weaker. So it has high chance of rupture. That's why we do not give incision in the upper part of the uterus these days for the cesarean section. Regarding the management, the treatment of uterine rupture is definitely surgical. Okay, definitely surgical. Immediate cesarean delivery of the fetus is imperative. You don't have any longer time to waste there. You need to take the lady immediately to the operation theater and take the baby out. After you take the baby out, okay, repair the uterus. Okay, repair it, especially if she is young and if she has not completed her family. This is important point. If she is young and not completed her family, you repair the uterus after taking the baby out. You try to preserve the uterus. But if the lady is very unstable, if the uterus is completely ruptured, if she has completed her family, okay, and if she doesn't want to continue to bear the family in the future life or children in the future life, then hysterectomy can be done. Hysterectomy is removal of the uterus. So these are some of the important points regarding uterine rupture.